Okay, thank you. Um, and we're going to be talking about urine drug testing today, specifically unexpected results, what might be some of the common reasons, and then how you manage that in a clinical setting. Oh man, having problems with my earphone here. Okay. So I guess I start with talking about what I'll call the presumption of innocence. So I might get an unexpected result, and so I always try to figure out, what else could be going on besides the fact that the person is, might have relapsed and might be using and doesn't want to tell me about it, which is obviously the most obvious thing. But there could be other things going on. So I just try to keep an open stance. I like to think about it that if I got a drug screen result like that, I'd want a little bit of a little bit of understanding or leeway if there was a strange story behind it, or if this was my kid and, something was going on. I guess I would want to know what the other possibilities could be. As a treatment provider, I have to sometimes remember that I'm not the police. Sometimes we in the treatment world are either trained like that by our mentors, or that's kind of how the program is that we work at. And so sometimes we can pick up on some of that terminology or some of that attitudinal stuff. And I sometimes have to remember, I'm not here to get anybody arrested or get anybody to go to jail. That's not my job. So that helps me as well. And then I also remember that the urine drug test, if there's 10 or 12 pieces of the puzzle, the urine drug test result is one piece of the puzzle. So what are the other 11 things? Have I thought of them? And how is the patient doing in those areas? Sometimes my patients, and again, these are more the savvy ones that have been around for a while, they'll say, "Oh, well, you don't trust me." And my, my response is, "Well, I trust you. I just don't trust your disease, and your disease wants to keep you sick. And in fact, it wants you dead." And so, so that's why we get, urine drug screens to increase accountability and make sure that you stay alive. So I try to use the disease of addiction sometimes as sort of the other, and then I ally with the patient against their illness. So sometimes that stance works. I mean, again, not everything works for everybody, but the more tools you have in your toolkit, the better. So what are those 11 or 12 pieces of the puzzle that I'm talking about? I'm talking about evidence of a recovery existence or a recovery life. So is the person going to meetings? And I don't just mean going to meetings, like, yes, it's hard to go to meetings in the middle of a pandemic, but people have found a way to do it through Zoom meetings and online meetings and things like that. So are you going to meetings? Do you know what the steps are? Are you working the steps? Do you have a sponsor? Do you have a phone list? Do you have a home group? So don't just ask the patient if they're going to meetings, get some detail about it. So the level of detail will help you understand what that patient is or is not doing. Because if they sort of look at you cross-eyed, if you ask them what step they're working on, then you could be pretty darn sure they're not working the steps. So is the person attending their counseling or their other intensive outpatient treatment? Are they coming to their appointments, on a regular basis, or are they kind of, missing in action all the time? Who are they hanging out with? Do they live like in a sober house? Do they hang out at sober places? Prayer, meditation, exercise. Again, I go over all those things. And then what's going on in terms of their housing, their employment, and or school. If that's going well, then that makes me feel a little bit more comfortable. If those things are going poorly, then I kind of know that they're probably not sober. So, and I can probably tell that just by just by listening to the story, like, yes, I'm homeless and I don't have a job, and I'm living in the basement somewhere. And it's like, okay, so even if you give me a urine without any issues, then I'm still guessing that there's stuff going on. The other thing I look for in terms of attitudinal stuff is there's an acronym that is very popular in the 12-step programs. And so when they ask, or when a person asks that's new to the program, well, how does this work? So the how actually stands for honesty, openness, or sometimes you'll see it written as open-mindedness and willingness. So if the person that you're working with is honest, open, and willing to do something about their recovery, that is sort of the proper mindset. If they're lying to you, if they're closed off, and they're basically crossing their arms and not willing to do anything, that also is a huge clue that they're probably not living a recovery lifestyle. So again, I put all those things up on this slide against their urine drug screen results, and then I say, can I figure out what's going on? And I also remind my patients that I'm not the police, and that it's much easier if they just tell me the truth about what they're doing. And, I respect them enough, and I'm not going to kick them out of program. And, and sometimes they need to hear that, because many, many times when they've used in the past, they have been kicked out of treatment. And so one of the ways they're trying to desperately stay in treatment is to lie about the fact that they're using. So it's very twisted. It's very ironic. I wish it wasn't happening anymore, but that is still sometimes happening. And so I just wanted to point that out. So I will go out of my way to say, please be honest with me. I'm going to work with you, but it doesn't work if you're lying to me. So if I'm, giving the patient the benefit of the doubt that day, then I have to figure out what else could be possibly going on. So I have to think about any other plausible explanation, and I have to consider how likely those plausible explanations are. So again, you can only go with I was in a car with with 5 people that were smoking pot, and, the smoke was really thick, and that's what, it's like, okay. So, I've heard most of the excuses in the book. One of the things I love about my job is, like, every week I hear something that I've never heard before. And so that keeps me kind of going. And one of these days I'm going to write a book and write all of them down. I will ask open-ended questions. I'll kind of play like Columbo, or play sort of the dumb detective. Well, geez, you said you haven't used cocaine, but yet I've got your urine drug screen has greater than 1,000, nanograms per ml of cocaine. So that's just not like an accident. So I wonder how that got in there. What can you tell me? What was going on when that was going on? And so sometimes the patient will either fess up or reluctantly tell me some extravagant story. So we eventually get there. And then once that is sort of out on the table, then really the issue is, so now what? So now what do I do? Or now what do we do? Um, and by we, I mean me and the patient. So does this mean you have to come in more frequently? Do I have to increase the amount of prescription that I give you each time? Do I have to test you more frequently? Should I be testing for different drugs? Should I be observing your test? Should I be watching the pee go into the cup? Should I be using a different matrix, like saliva, hair, sweat? I mean, if you have that capability. And then finally, if the person continues to use and you've got them at a particular programming level, they just might need more intense care or a different level of care. So that's kind of, this is sort of the things that go through my mind as I'm working with the client. So let's start out with what you ought to see on the urine drug test. Ought to have a good temperature, so a temperature that's close to 98.6 or even a little bit lower, because as it's coming out of your body, should be around somewhere in those high to mid to high 90s. The creatinine ought to be within normal limits if your lab can test that for you. You do have to make sure that you've done confirmation testing. I will probably say that about 6 more times in this presentation. So the most important thing you can do is figure out, is the test that I'm looking at a screening test, or is it a confirmatory? If you are prescribing Suboxone, then you ought to make sure that buprenorphine and its primary metabolite, norbuprenorphine, are both present. And then you also are hoping that all other substances of abuse are absent. But remember, if you don't test for it, you won't find it. So yes, your patient might not be using cocaine, but if they're using kratom, or they're using K2 or spice, and your drug test doesn't test for that, well, of course you're not going to find it. It's kind of like, hey, our COVID numbers are down. Well, how much testing are you doing? Well, we're testing 0.5% of the population. So, okay, so how do you know what your COVID numbers are? It's the same thing. So, if you're not testing, you're not going to find it. So I guess that's my point there. So I hope you're not too intimidated by this slide. You're going to see the most common scenarios of things that could happen to you, and there's going to be a single slide for each one of these scenarios. So we'll start out with that. You get a urine drug screen that looks apparently like nothing is going on, but your patient is acting very strangely. And by strange, I mean any number of things. So as I already alluded to, are they using something that you're not picking up? And that's why they're acting strangely. Are they having some sort of medical cause that is causing their behavior? Blood sugar problems, infection, some sort of seizure, a head injury. And then the other thing is, of course, a primary psychiatric cause. Are they manic, psychotic, or in the middle of a very sort of bad panic reaction? And so the right-hand column is some of your strategy notes. Make sure you know what your screen is actually testing for. If this means that you have to talk to the pathologist at the lab, then talk to the pathologist at the lab. If you can get a different method of testing, try that. Like I said, call the lab if you can. And then if you can check vital signs, or if your clinic has the ability to check a blood sugar, all of those things are good, because then it'll give you more clues as to what might be going on. The second scenario is that your urine drug screen does have things in it, but the confirmatory testing is negative. So again, please beware of the unconfirmed test due to the false positive. Every lab and every test will have different false positives as well, which is why I say you sometimes have to talk to somebody or read the fine print. The most common one that I see in my day-to-day practice is that a patient that I have on Wellbutrin, typically higher doses of Wellbutrin, 300 milligrams or above, will often test positive for amphetamine or speed. And then when I go to the confirmatory testing, the amphetamine is negative. So then I know that it was the Wellbutrin they were taking. But I don't, after this happens to you a few times and you're like, oh my God, my patient's relapsed and they're using speed. And then you realize, like, oh yeah, that's their Wellbutrin. So I don't get too, my blood pressure doesn't go up too high until I see the confirmatory. And then I was like, okay. So you can redo the test, you can confirm it. The best way to do it is if your lab will do reflex confirmation, then you don't have to think about it. So anything that comes up positive, your lab will automatically then send that test for confirmation. Obviously, if the test comes up all negative, there's nothing to confirm. So if you want to set up your screening that way, that works very well. You have to have a list in your head of the common drugs that can cause false positives. I wouldn't necessarily go with the lists that you get from Dr. Google. There are some better sources than that. We have some of those sources up on our website. I typically start with the list that is in the American Society of Addiction Medicine textbook. I believe it's chapter 19, and there's like an exhaustive list of all the things that can cause false positives commonly. My other favorite one is, I can't remember, there's something that comes up false positive for PCP. Maybe somebody on this call knows what it is. So it's always interesting to get, like, the 70 or 80-year-old lady that's in the hospital and they come up positive for PCP, and you're like, nah, man, there's no way. So most of those cases, I don't think there's been a single case where it was a 70 or 80-year-old using actual PCP. Usually it was something else that they were taking. And again, in terms of strategy, please, if you have the authority to do it, I would advise you not to make big clinical decisions like putting somebody in jail or prison, or kicking somebody out of a program, or calling Child and Family Services on somebody. Please don't make those kinds of big clinical decisions based just on a screening test, because you may have to eat crow and you probably won't like it. So get it confirmed first. The third most common scenario is the games that your patients or your clients will try to play, because they're going to try to tamper with the test, whether it's with the temperature or something else. So it's good to have the temperature strips that you can put on your drug screen, or your little cup. If the sample keeps coming up dilute, that can point toward tampering. There are certainly things you can buy. My favorite website that I learned many years ago is called Urine Luck. So URINELUCK. I don't even know if that website is still live, but then, they'll sell you something that you can put into your urine. It usually, it cracks me up, right? So I've actually had, the opportunity to handle a lot of the urine drug screening myself. So you just get used to what a urine is supposed to look like. And so when sometimes people put these chemicals into the urine, it looks like fluorescent yellow. And there's no human being that pees fluorescent yellow. So when I see the fluorescent yellow pee, it's just a sign like, yeah, there's probably something else going on. Unless the patient is, like, I don't know, radioactive for some reason. No, I'm just kidding, actually. So I will usually call the patient out on it. So it's like, man, you're going through lots and lots of, hoops to try to trick me. What is it that you're afraid I will find out? Why don't you just tell me what it is that you're afraid I'll find out, instead of going through all these hoops? So usually the patient will back down after that. You always have the right to ask for a new sample. So yes, the urine you gave me is like ice cold. Can you maybe give me a fresh sample right now? And then some places will put dye in the toilet so that the patient can't take their little cup and scoop it into the toilet water and, that kind of thing. So if you have the ability to put dye in the toilet, that's great too. If you're a very, very, very fancy office, you also have the ability with the flick of a switch to turn off the water in your bathroom so that the patient can't, put a little bit of water from the sink tap into what they're what they're giving you. And then also too, the water looks, or the sample will look extremely clear, which could be urine, but I mean, again, if you could see completely all the way through it clear, it's probably just water from the tap or from the toilet. So I am interrupting our regular programming to bring you, again, a picture of the links that people will go through. This is sexist, I realized, because there's not an easy way for girls to do this. Well, I guess it is easier for women and girls. But anyway, if you're really desperate and you want the Wizinator for $139.95, you will get this very nice, culturally specific, comes in 5 colors, realistic fake penis with medical grade synthetic urine and an ultra quiet flow system that you can operate with one hand. So certainly somebody's making lots of money for people trying to come up with ways to fake their urine tests. So that kind of tells you how important it is to people. So, and it is, because if it's the difference between you being in jail and out of jail, yes, you might consider spending $140 on it. I personally have not had the pleasure of actually seeing a Wizinator, but yes, I have heard stories, and yes, they do exist. So that would definitely be a first. Now let's go into some of the scenarios where we're talking about specific substances. So again, in my business, the most important thing, or one of the clearest pieces of evidence is if that a person is not taking their medicine the way they're supposed to, is if I get the urine drug test that is positive for the buprenorphine, but negative for the metabolite. So that usually indicates that a client has taken a little bit of the buprenorphine film or a small crumb of the buprenorphine tablet, and they've actually sort of melted it and dissolved it into the urine cup. And so what's happening then is you're just getting a lot of the actual molecule of buprenorphine, but there hasn't been any breakdown of the buprenorphine through that patient's liver. And so that's why you're not seeing the norbuprenorphine. And so patients think they're kind of being clever, and you're kind of like, yeah, I've seen this one already 100 times. So no, that's not going to work. Again, I just tell my patients once again, look, this is indicating such and so, and if you would just tell me the truth, it would be so much easier. And then again, if it's happened multiple or more than once or more than 2 times, it's kind of like, well, if this keeps on happening, the best thing to do is, it's clearly not in your system, so I might just need to stop prescribing it to you. So that typically gets people's attention. What if the urine drug screen is negative for buprenorphine? So they're not taking it at all, and they don't even bother to try to fake it that they're taking it, but at the same time, it's negative for all other drugs of abuse. So, and the patient's telling you, look, I'm sober, and I'm taking my medication. So on rare occasion, so 1 out of 50 times, and you look at all the recovery indicators in that person's life and they seem to be doing fine, then I'm kind of like, hey, I'm curious about how they're taking the buprenorphine. Sometimes if they're breaking it up too many times during the day, like they're taking it 4 times a day or something, and or they're like a rapid metabolizer, that could be a reason that you don't see it. The other thing is, or the other obvious explanation is, they're diverting it to sell it for something that you don't test for, which is why you then don't see it in terms of the other drugs of abuse. So once again, it's sort of like, hey, I got these drug screen results. I want to talk to you about them. It doesn't make any sense for me. And then you want to maybe try to send it out for something else that they might be using. And then you might also want to consider, can you test them at different times of the day? So just to see if you can get some indication that it's there. What if the urine drug screen is negative for buprenorphine and it's positive for other drugs of abuse? This is probably your clearest example that they've either sold it to buy other drugs, or that they just stopped taking it for whatever reason. And so again, in terms of strategy, look at your other list of recovery-related lifestyle activities. And if they have very few of them, then that sort of gives you the answer to your question. And again, sometimes I will try to get the patient to ally on my side and guilt them into it a little bit. And I say, hey, man, the feds are watching me and the state folks are watching me. This does not look good. I can't keep prescribing in this situation. So, um, help me stay employed and help out all these people that need their buprenorphine. But I can't keep doing this. So sometimes I've had some luck with that. And then I'll go through the specific drug classes. So yes, they're taking their buprenorphine. Yes, you can see the metabolite, and they're taking marijuana. So remember, again, the reminder, buprenorphine is not a treatment for marijuana use disorder, so it's probably not surprising. And if they're admitting to smoking or taking marijuana, you might want to wonder, like, is there anything else that was mixed in it? That might help you find something else, if there's something else there. I try to get quantitative levels from the lab because marijuana sticks around for so long. So I want to know, is the marijuana level 750 or is the marijuana level 75? So that sort of helps me make some decisions. And then if they're saying, no, I really need this stuff for my XYZ symptom, then I try to get into that symptom and figure out, is there something that I can give them instead of that? And then also reminding patients that there is such a thing as marijuana withdrawal. So it's possible that you're using pot to cover up the anxiety that you get when you're in withdrawal from not using pot. So have you really gained anything? And if you just stopped using it, then you wouldn't have that symptom to begin with that you'd have to treat. So most patients don't go for that. They they seem incredulous when you tell them that. Like, yeah, you could just be medicating marijuana withdrawal. They're like, no. It's like, yeah, that's probably what's going on. What about the uppers? So if they're taking stimulants that you aren't giving them, or that you can tell, it's like, we don't typically as doctors give out methamphetamine. We certainly give out amphetamine in the form of Adderall, but we don't give out methamphetamine. So the test that I have at work can show me the difference with that. So again, the reminder, buprenorphine is not a treatment for stimulant use disorder either. Quantitative levels also super helpful. And remember that the person might be ready to quit using opiates, but not ready to quit using stimulants. And so some of my toughest cases right now are people that clearly are taking their buprenorphine, no problem, not taking any opiates, but they have horrible, horrible time trying to quit cocaine or quit methamphetamine. It's just been the bane of my existence. A couple of my patients are having just a really hard time. So trying to get them back into treatment is basically what I've been doing. My other favorite case that I think of is a woman who had cocaine levels that were so low that I did start to think about secondhand crack smoke, which is a thing. You can actually look it up. So I thought, wow, could this be a case of secondhand crack smoke? And what it actually was a case of was she was helping her significant other slash drug trafficking boyfriend to pack up cocaine in little baggies, and she was doing it for so many hours a day that she was actually absorbing levels of the cocaine through her skin, which was giving her levels in the urine drug screen that I was able to pick up. So yes, I actually got her to tell me that story. So you can't make this stuff up, people. So I said, hey, what are you, a person in recovery, doing with the drug trafficker who is, quote, making you pack up little baggies of crack? That really does not fit with a recovery lifestyle. So eventually she stopped doing that. But it was a lot harder to get her to break up with the boyfriend. The benzos, when you start to see those in the urine, that's when I start to get concerned. So again, I start to get excited with scenario 9 or scenario 10. So scenario 9, now they've got benzos in the system. So they've got Xanax or Valium or something like that. I think this is one of the toughest situations that I'm in on a daily basis, which is, I feel like I'm walking the tightrope, and I have to explain to them that, there's a high risk or a higher risk of overdose and death if you're combining multiple downers. Again, it's possible that the buprenorphine just is not the thing for them. They might need Vivitrol injections. They might need, to go to a methadone clinic. So they just might need something else. So this is sort of, I get to that point sometimes with these clients where I'm like, look, what we're doing, it's not working out. We're going to have to do something else. So it turns into a pretty short conversation after that. So, and they get it. So, And then finally, if the drug screen shows that they are taking their medicine, but they're still using opiates on top of it, well, then that tells me a couple things as well, which is that, again, the current dose that I have them on is inadequate, or if I'm already at max dose and they're still using on top of it, then again, we got to go back to the drawing board because this clearly isn't working out. Um, then I start to think about, where am I at in terms of the buprenorphine dose? Can I go up to 24 milligrams? Do I have any room to move? And so that's a very clear yes or no. So if there's no room to move, we've got to try something else like methadone or naltrexone. But I don't, again, it's not a reason to kick somebody out. And particularly, again, you talk about pet peeves, is when people are in the first 30 days of trying to get sober and they come up with positive drug screens for opiates in like the first 2 to 3 weeks. That's just the person trying to get sober and you trying to find the right dose. And it is super duper frustrating to me when people get discharged because of that. Because you're like, wait a second, you've got this person on 8 or 12 milligrams. They might need 16 or 20. Here you go. You're about to kick them out. What do you think is going to happen? It's like, I know what's going to happen. They're going to go back to opiates and possibly deadly combinations of like fentanyl and other stuff. So I'm like, oh man, please give them a chance at least to get them on their feet. So what if you can't figure it out? There's many cases that are unfigure-outable. So again, keep going back to that. Hey, I would much rather you tell me the truth. I'm not going to judge you. Not going to, well, I can't promise you that I won't kick you out, but 9 times out of 10, I'm not going to kick you out. Sometimes the best thing to do is wait. If the person is, messing around and in active addiction, it will always catch up to them. So I don't ever worry about that. Remember that the toxicologist at the lab is your friend and you can call them. You could always consult one of us on the echo, or hey, you can always write up the case and bring it to the echo. Shameless plug. So we love to hear about those fun cases. So also, yes, and speaking of fun cases, one of the most fun cases, this was not my case, this was a case of a colleague of mine, is the notorious Vicks inhaler. So the Vicks inhaler, if a patient is using it, and I understand you can still get these things, the Vicks inhaler will come up positive for methamphetamine. And you have to then ask your lab to distinguish between the methamphetamine that rotates to the left versus the methamphetamine that rotates to the right. And then that's how you can tell if they're actually using methamphetamine or just using the Vicks inhaler. And so my colleague did actually take it to that level. So that's a fun one. But, such an odd question. You would not think to ask, hey, by the way, do you use a Vicks inhaler? And I never plant the seed of what it is. I mean, again, that's like, that is cops 101, right? So don't ever say what you think it is. Like when I call somebody and I say, hey, you had something on your drug screen. What was it? What can you tell me about it? I don't ever say, hey, you had Coke or you had marijuana on your drug screen. Hell no. Don't give them the information. See what they tell you. So again, some of it is fun and it's kind of detective work. But yeah, most of the time I'm pretty straight shooter. My clients know that. So there's a lot of great references out there, starting with Tip 63, which was published in 2018, the ASAM guideline published in 2017, and then there's an older white paper published in 2013, and I've got the references there. And now I'm going to stop